So it's my pleasure to welcome all of you to Advanced Practice Grand Rounds, and also to introduce Dr. Bach. If you haven't worked with her, she's a fantastic clinician that has provided so much nice guidance for our surgical population, particularly the ones that are medically complex. So I know that you're going to enjoy the lecture, so please join me in welcoming Dr. Bach.
Thank you very much. Can you hear me okay if I stand like this? Because if I stand here, I need like a boost chair or something. Yeah. Anyway, my name is Huong. I'm an internal medicine doctor. I have a joint appointment with anesthesia, but the last time I did anesthesia was like 1986 when I was a medical student. And today we're going to go over some pre-op risk assessment. And even though the heart is not the only organ in the body, it caused the most heartache and headache for us in terms of case cancellation and delay. So I'll spend almost all the time on cardiac risk assessment. There's a lot of slides here, and I hope you have access to the slides, yeah? Can it be given to a Dropbox for you so you have them? I'm just going to focus on maybe like 30 slides. The rest are pretty straightforward. How do you go forward? There you go. Okay. So as those of us who've done pre-op, we know that we don't clear patient for surgery, we identify risk. Because in the end, we operate on high-risk patients because they need the surgery. And so our responsibility is to gather medical information, help the patient see why are they having the surgery, what are the net benefits, and has their health been as good as it's possible before this procedure. So we identify risk, and we do not clear patient for surgery. There are three types of risk. Risk based on the system, which we're going to go first, risk based on the procedure itself, and then risk based on the patient's health, which is what we're going to spend most of our time today. System-related risk is a thing that we go home grinding our teeth every night because there are just too many cooks in the kitchen, and the right hand doesn't know what the left hand's doing half the time, even with EMR. So the classic example is somebody got a bunch of lab facts from Feather River, and it sits on somebody's desk, and everybody calls Feather River, and they say, we've sent it to you already. And so share the information. You know, actually the best starting point is when the referral person receives a request from outside. Besides asking the information pertinent to the surgery, we should have some medical information too, just at least some record so that we know who this person is. Because the choice of the surgery depends not only the structural problems for the surgery, but also the patient's health. We certainly would not offer a very big procedure if you have a very frail patient. So share the information, put them all in MR, and the key thing is make the instruction very clear. So for example, if you call the pediatric cardiologist who said, okay, do this, do that, and don't do this, document in your note. Talk to Dr. XYZ, phone number is, or pager number is, and the instruction. Stop clopidogrel 5 days before surgery. Continue aspirin. And so that people downstream to you can look at that rather than try to page you, several times trying to get the same information. And now procedure-related risk, don't like the procedure-related, don't have the surgery. And there's, from a cardiac standpoint, it's cardiac death and non-fatal MI. And low risk is when the risk less than 1%, and that would include ambulatory surgery, endoscopic, superficial, breast, cataract surgery, and everything else is non-low risk. And that's actually all we need in terms of differentiation. Patient-related risk, we're going to spend all our time on this now. We're going to focus on cardiac, but keep in mind that there's pulmonary, there are venous thromboembolisms, and nutrition, there are many a risk factor too. Communication is key. And sometimes we speak in parallel with each other. The classic example is I had this patient who had a spinal decompression and had multiple complications. Is this too loud? Should I step back? Okay, good. Let me know if it's too loud. Had major spine surgery, had major complication afterwards, had prolonged intubation, the wound didn't heal, had a PE, had pneumonia, and 6 months later the patient would say, but my feet still burn. It turned out that the thing that was disabling for the patient was a stocking glove neuropathy from diabetes, to the point it was so exquisite that he couldn't even put the bed sheets on his feet at night in the winter because it hurt so bad. And those was still there, even though the hernia it was fixed. So it's very important for us to establish upfront and help the patient crystallize what is it that we try to resolve. Is it a structural problem? Have we exhausted all of the non-surgical treatment first? Because surgery should be the last option and not the first. And then, identify what the patient goal and expectation are. Now, there's two types of risks that we gather the information. One is a modifiable risk, which are the risks that we can change. For example, an asthmatic with a cold, on antibiotics right now, on inhaler, well, technically you're not supposed to be on antibiotics for a cold, yes? Having active tooth abscess as an open wound, patient who used to walk 5 blocks before they have chest pain, now they walk a block and they get shortness of breath and chest pain. So these are new. So when we do the pre-op risk assessment, the first thing we ask is, what is your health like, and has there been any change? And is the change significant? Should we address that before the surgery? So modifiable risks should always be optimized before surgery. First is a non-modifiable risk, that the risk that we identify, but we cannot change. So for example, someone with end-stage liver disease that is compensated, unless you do a liver transplant before you do a knee replacement, then that's a non-modifiable risk. Likewise, if the patient who is bed-bound, stroked out, too fat, multi-organ failure on hemodialysis and became short of breath when we roll from the bed to the commode, but it's been that way for 6 years, that's a non-modifiable risk. And so the question is, what will be the net benefit? If the benefit for the surgery is here and the risk here, go for it. But if the benefit is down here and the risk is like this, then you want to scratch your head and think really, really hard before we would do surgery. What happens if you have someone who has critical aortic stenosis? And this is a true story. I had a very feisty 85-year-old lady with critical AS, and she known it for years. And, you know, even all the doctors were like her students in middle school and kindergarten school. And so she wanted her knee fixed. She came all the way from Fresno. She's been to many doctors along the way and ending up here with us. And she articulated so clearly, I know I could drop that any moment because my valve is so tight, there was not enough blood flow go through that, and I can either die because my blood pressure is too low or I had an arrhythmia. I want you to fix my knees, I can walk my dog. And so that is an informed decision. So the question is, are the surgeons and the anesthesiologists comfortable doing the procedure? And so in that case, that's an informed choice. And again, we want to differentiate that because it matters for us to provide adequate informed consent. Now, from a cardiac risk assessment, there are 5 elements only. Have you had heart disease, CAD? Have you had heart failure, ever? Diabetes? Kidney disease? Have you had a recent stroke in the last 6 months? That's it. What happened to hypertension, hyperlipidemia, smoking, premature family history of coronary disease, family history of premature coronary disease, hyperlipidemia, menopausal state. All of the other stuff are not written down. A risk factor for atherosclerosis, but they are not risk factor for postoperative cardiac complication. Yep. So the usual mindset, okay, my patient has hypertension, is going to have spine surgery, I need to do a stress test. That would not be correct. Yeah, so only these 5 elements, and then we'll go over one by one. Now, function matters a lot, and function is everything. 4 metabolic equivalent is the ability to climb 2 flights, well, it's actually more than that. 2 flights of stairs, and a flight of stairs is 14 steps, right? Not 2 steps. And then 4 flat blocks without symptoms. So make sure that your history is very clear and document that. You know, the patient does Zumba an hour 3 days a week, done. You pass the stress test of life. Play racquetball 3 hours a week, done. So write down what they do rather than, you know, just 4 mats, 10 mats, or whatever. So if the patient passes stress test of life, why order the test? Yeah, and in fact, some of the tests are not very helpful because you know, if the function is already good. And why do we say that? Because this is actually a really neat finding, is that the risk of complication is low if you're able to, for non-elective cardiac surgery, if you can do 4 flat blocks, 2 flights of stairs. That's why we hold it at, you know, that level. Okay, now there are 3 methods for cardiac risk assessment. On the far left, Revised Cardiac Risk Index, or CRI, or also CRF for cardiac risk factor. This is Lee and Goldman criteria. endoscopy criteria. Again, the 5 that we talk about: heart disease, heart failure, kidney disease, strokes, and diabetes. That's it. And that's actually the most widely used now. There are 2 new emerging types of risk assessment that you can use too. The one in the middle, I'm just going to bring it up, but we're probably not going to use it. It's called the Gupta calculator. And the Gupta, NSQIP stands for the National Surgical Quality Improvement Program. Yeah. So the Gupta has 5 elements: age, kidney disease, function, surgery type, but it's very broad stroke. You know, you have GI surgery versus GU surgery, and then the ASA classification. But the one that you most likely will use later on in some clinics, like GI surgery clinic, Dr. Farkas using it now, is called the NSQIP surgical calculator, and it's so fun. You go on that, you know, there's 20 demographics, age and previous heart surgery, and you just click yes, no, yes, no. It takes maybe like 4 or 5 minutes to do, and ka-ching, this is what you get. So you type it in, and it's based on the experience of 1.5 million patients and like 1,000 different surgeries. So not just posterior spinal fusion, but how many levels, is it anterior, posterior, etc. So it gives a much more granular picture. And then you click ka-ching, and you get this. And you know, you probably won't be able to see it, but you know, when you go home, just play with a calculator. It's really fun. So it would have, you know, what is the chance of you having UTI, the length of stay, cardiac risk assessment, etc. So it's actually really nice. The patient come home and look at it and, should I do this? Yeah, rather than, you know, when in the old days when we have to handwrite the consent, you know, PE, DVT, and MI, CVA, and nobody knows what it means. Yeah. Okay. So, what are the elements of cardiac risk assessment? Old-fashioned way, talk to your patient. History is everything. People don't realize how much time. That's all I do. I just sit and chat with the patient. So, you know, the intern and the resident use see me and say, so Dr. Bach, what is the patient's dog's name? Because I spent so much time with them. So get the history, do your physical, and sometimes you need an EKG if they have cardiac history. And then the question is, in what circumstances will additional testing be indicated? In fact, that's why you're all here, yeah? When would you order a test? And you do it for 2 reasons. One, if you have new symptoms that seems cardiac in nature. Now, what does that mean? Well, not all chest pains or shortness of breath are equal. So if we were to go to all-you-can-eat buffet at the Japanese restaurant, had too much sake, and wake up middle of the night with pressure, heaviness, diaphoresis, symptom, are we having esophageal spasm, or are we having unstable angina? Should we get a cardiac cath now? The answer is heck no. Yeah. So the quality of the symptoms matter, and you know, getting a good history matter. Now, for people who just come out of schools, you tend to be a little bit more anxious because you know, experience is defined as the level of comfort you have with uncertainty. You know, I remember when I was an intern, I would freaked out because I wasn't sure whether I gave too much potassium, so I called in like at 3 in the morning and said, what's the K? Is the patient okay? And it's like, Huong, you were post-call today. Why are you calling us? I said, I just want to make sure so I can go back to bed. And so over time, then you become more comfortable. So for example, if you were to see someone for chest pain in the clinic and say, that sounds GI, let's try the GI cocktail and I'll see you in a week. I'll come to the emergency room if this happened. And a week later they showed up, it validates your decision. And over time, you feel more comfortable making those calls. Early on, you could be like, I just want to be sure I want to order the test. Right. So new symptom that seems cardiac in nature. So what is the pre-test probability of that chest pain, that shortness of breath be cardiac? If it is, we want to know, is it angina or not? That's 1. 2, if the patient in their usual health, but now that they're considering having spine surgery, then in what circumstances will additional testing be indicated? And that's what the ACC guideline is for. ACC stands for American College of Cardiology. And you look at it and say, I don't know what that means. And I don't either. And I do this for a living. So we go to the next one. So this is 2007. And the other one that could not be decided is 2014. And I look at that. Why are we making it more difficult than it is? It's actually very logical. I mean, medicine is incredibly logical. And we don't want to confuse each other here. So this is the schema. but I'm going to go back to the narrative to make it easier to read. There's a series of questions that you ask on the ACC guideline. Again, it's a guideline, it's not a protocol. So I break it all the time. But if I were not to follow the guideline, then I would need to articulate in my note, why not? And did I talk to the patient? Are they okay with that? So the first question, remember this is for patient who in their usual health but now consider surgery. So we're going to ask the following question. 1, is this an emergency surgery? If the answer is yes, you get a history. Is there any modifiable risk? Non-modifiable risk. Example, patient just had an MI yesterday or heart failure or stroke yesterday, but now they have peritonitis. Then you would tell the patient, you have a hole in your stomach, you had a heart attack yesterday, we usually would like your heart to heal for at least a few months before we consider surgery. But because you have a hole in your bowel, it needs to be patched up or you'll die from peritonitis. These are some of the things that can happen to you, and these are the steps that we can take to minimize those risks. And so that's an informed decision. Likewise, if you were, so you would use that for informed consent. Now, if it's not emergency surgery, I'm going to have a 2-level posterior spinal fusion. Go to the next question. The next question is, are there any active cardiac condition defined as acute coronary syndrome, decompensated or new heart failure? Think of heart failure as like having a fever. Fever from what? Fever from a bacterial infection for which there's targeted antibiotics used, or viral infection for which tincture of time is the best treatment unless it's the flu, yeah? Or it is an inflammatory process. Same with heart failure. Heart failure, you would treat the heart failure with diuretics, but you also would want to know heart failure from what? Is it from systolic failure when the pump fails? So your usual ejection fraction of your heart is 50-60%, but if it's 20%, and that's why you have heart failure. The question is, what caused that heart failure? Is it from coronary disease, from old heart attack, new heart attack, whether it's from amphetamine, whether it's from chemotherapy like adriamycin, whether it's alcohol related? So you would want to treat the heart failure in addition to the underlying cause as well. So the other heart failure is diastolic failure, when the pump is very strong and vigorous, but you have a downstream problem, so like severe hypertension. If your blood pressure is 240 over 140, your heart has to squeeze against that pressure and it's going to poop out. So it's kind of like on a really windy day when the wind blows against your front door. You try to close the front door, you have to lean really hard to slam it shut because you have to slam that door against that wind, that crosswind. So same with diastolic failure. That's all it means. So you treat the heart failure by treating the blood pressure. So if you have heart failure, you want to treat that. Do pre-op heart failure predicts post-op heart failure. So don't mess around with elective surgery. Yeah. If you have dysrhythmia, arrhythmia come in 2 flavors, fast and slow. If you have symptomatic arrhythmia, don't do elective surgery. If you were to have valvular heart disease, the big one is critical aortic stenosis or mitral stenosis. If you have symptomatic heart failure, don't do elective surgery. So if the answer is no, I have 5 block-induced angina, go to the next question. So the next question in the old criteria is, what kind of surgery do you have? Low risk. So low risk is like cataract, breast surgery, superficial surgery. But now with the use of the NetScript calculator, you just type it in and ka-ching, you get a number. If it's less than 1%, go to surgery. Don't do any more testing. Yeah. So if the answer is, if it's not low risk surgery, then you go to the next question. The next question is function. Function is everything. I don't care what your ejection fraction is or your FEV1. If you walk 4 blocks, you climb 2 flights of stairs, you're good to go. Yeah. So if the function is 4 mets or more, go to surgery. If the function is less than 4 mets, then why? Why can you not walk 2 blocks or 4 flights of stairs? Because my knee's killing me, that's why I'm here. Or it's because of, I'm paraplegic from a diving accident in high school, or whatever reason, or I have shortness of breath or chest pain from critical aortic stenosis. Well, no, we wouldn't be here by now, but so why your function is poor? So if the function is poor, and then we're going to go to, okay, and some of the risk factor here. And can you see it on the bottom? If you have 3 or more, so if you're unable to walk 4 blocks or 2 flights of stairs, and if you look to it will be your left, no clinical risk, meaning I'm a hypertensive, smoking, menopausal woman, I get 0 point, send me to surgery. It's like, really? Don't you want to be sure? It's like, no. Yeah. But if you have vascular surgery, consider testing If it will change management, I said, oh my goodness, people who write this guideline don't do frontline work, right? That's why you write something like this, and I need better marching order than that. If you're somewhere in between, I am a diabetic on dialysis, so you have 2 points, and you can undergo other surgery, then proceed with planned surgery with heart rate control, beta blocker, or consider non-invasive testing if you could change management. What does that mean? Well, the first question you actually should ask is why you're having the surgery. Yeah? If you would have a broken hip, can that femoral neck fracture wait for you to do all of these testing? Because, you know, if you're going to do a stress test, if the stress test is abnormal, can you do an angiogram? If the angiogram is abnormal, is that time to revascularize the patient? If you're going to do a CABG, you want to wait at least a month for the body to heal. If you're going to put in a bare metal stent or do angioplasty, then you would want to be on aspirin clopidogrel for at least a month so you don't clot out that new stent. If it's a drug-eluting stent, 6 months to a year, depending on what kind of first or second generation stent you use. So can that broken hip wait for me to do all of these interventions? The answer is no, because this is a time-sensitive procedure. So the first question we actually should ask is why are you having the surgery? Yeah, because if it's an emergency surgery, why order all these tests? You use information to help the patient see, you know, have a big picture of what are some of the risks involved and what are some of the steps we can take. So that matters a lot. Why you have the surgery? What are your medical problems? Among the problems, what are the modifiable risks? Things that you can tune up. What is your function? And do you understand your choice? Is this the right choice for you? Just because there is a structural problem, that doesn't mean, it's just because it can be done doesn't mean that it should be done. And, you know, people are really gung-ho. They come in, you know, give it to me. And then when you sit around and we talk about all of these things, I'll just try physical therapy first. Yeah. Okay. So now so the first question you ask is who need testing, right? You know, if you have new symptoms that seems very cardiac, we want to know whether they have surgery or not. 2, if you're going to go down the ACC guideline and think, yeah, I think that would matter, then what do you do next? Okay. There's many ways. One is echo, resting echo, so you should look at the ejection fraction. You can do a functional study like a treadmill to look at, to see if at certain function do you have ischemia. Or you do an angiogram, which is a structural finding. And sometimes, believe it or not, the structural finding may not be congruent with the functional status. So for example, this is the reverse of what you see, like when you the CCU and somebody come in with chest pain and boom, they cath them and say, whoa, there's this 90% distal obtuse, first obtuse marginal lesion, but the blockage is so distal. And by the time, you know, the vessel tapered off, so the farther down it is, the smaller the vessel. When it's less than 2 millimeters, if you put in a stent, you're going to rupture that vessel. So everybody scratched their head and say, well, let's do a stress test, which is a reverse, right? You do the stress test and you do the cath, and then you say, okay, here we do the cath first, and you say, I don't know what to do. And then, okay, let's do the stress test. What the stress test does is, is that lesion correlate with ischemia? And then should we do medical therapy, or we should try to do a stent or a cath? Yeah. So those are the 3 things you can do. Now, echocardiogram EF, a low EF, meaning systolic failure, and history of preoperative CHF predict post-op CHF. It's helpful for that. But knowing an echo, a resting echo, does not help you predict ischemia. So it's a useless test to look for ischemia. So now we have running the treadmill or chemical stress test. We'll go over that next. Oh, you'll love this. Remember, function is everything. So here, there's several studies. These are in the 80s, but it's actually still stand today. The inability to reach 85% of your maximal predicted heart rate is more significant than ischemic response. What does that mean? Well, when you go to the gym and you hire a trainer, right? New Year's Eve, we're going to do this. The MPHR, maximal predicted heart rate, is a constant. It's 220 minus your age. So each one of us would know what your maximal predicted heart rate should be. So when you run on the treadmill, you need to reach at least 85% of your maximum heart rate for your age for me to prognosticate you. If you're able to reach that, most patients do really well. And these are some of the data. It's hard to see, but they see here that the positive predictive value and that negative predictive the negative predictive value is very helpful. Okay, now let's go over that. For the patient that cannot do treadmill, which is most of your patients, right, then you do the chemical stress test, and there's 2 varieties. One is like diprotomal thallium, which is percentin thallium. Now we use LexiScan, right? And so instead of doing a treadmill and sweat, here you lie down, they inject a bunch of stuff in you, and it causes a vasodilation. Every blood vessel vasodilate except from the one with the blockage. So it causes a coronary steal syndrome. The negative therapeutic value is awesome, 90%. What does that mean? Out of 100 tests that has a normal result, over 90 of those patients did really well. That's what you want, right? If the negative test is very helpful. But what happens if you have a positive predictive value? It's 4 to 20%. That's really crappy, right? Because out of 100 abnormal tests, only 4 up to 20 of those patients had complication after surgery, which means that we just subject 80 to 96 patients to an unnecessary cardiac cath. And cardiac cath is not benign. You can shear somebody coronary, you can have kidney failure, it's a big deal. So what does that mean? Well, this test is really good if the test is negative, but it's crummy if the test is positive. Okay? And that is the same story you have with Dobutamine echo. Dobutamine echo is, you use an inotrope, so you increase the heart rate, you increase the blood pressure, and, did you have symptoms? Was there any EKG changes? And there's an wall motion abnormality. The negative predictive value is awesome. The test is very helpful, both of these tests very helpful if it is negative. But if it's positive, it's not very helpful. The question is, why is that? Well, predictive value depends on the prevalence of the condition in the population, which means, so for example, if you go to, the World Cup's coming up, or the NBA Finals, yeah? If you ask, you put all of the Warriors and the Cavaliers players on the treadmill, some of them is going to have abnormal tests because these are really healthy patients and the athletes, so they have left ventricular hypertrophy, they have all these funky SCG weight changes, they have early reposation. So it would not be surprised the test is abnormal, yeah? But, the EKG is abnormal, but the echo will be normal, right? Because they're really healthy people. So if you were to have a condition that is so rare, like 1 in a million people have them, all of the abnormal results will be false positive. But if you go to cardiology clinic or CT surgery clinic and you round up the first 100 and put them on the treadmill, all of the abnormal results won't be real. So how good of a test depends on how common that condition is in the population. So the point is, it cannot be used for routine testing because you're going to have a lot of false positive results. And the question is, what do you do next? Yeah, so you have to use it judiciously. But more importantly, there's something that we need to know, is that what are we afraid of? We hate death and MI, right? That's the common final pathway that we try to avoid for our patients. How many pathways that lead to that endpoint? There's 3. One is fixed disease. Fixed disease meaning the patient has a 99% LAD lesion. They sit around and, and now that you have surgery, you stress them and it manifests itself. So that's what we're looking for. I want to know among all of the couch potatoes going to be having surgery, which one of you have severe coronary disease, because the assumption is we're going to fix that disease, you're going to be safe for our surgery later on, right? That's the only reason why we're looking for disease like this. But if you go to the CCU, half of the acute MI is not because of fixed disease, meaning progressively 80-90% lesion. It's caused by plaque rupture. This is ACS, acute coronary syndrome. So if you were to do that treadmill or you do that stress test an hour before the event, it would have been normal because they may have a little plaques, really plaques along the lumen, but it's the plaque rupture that caused it to close. So it causes an acute thrombosis. We don't control that pathway because we always stop the aspirin and all of the antiplatelet before surgery, right? Yeah, so that's the second pathway that we don't, control. We're very big on control. But more importantly, almost a lot of the MIs and troponin leak that we see after surgery is from demand ischemia, okay? We nick a vessel, got hypotensive, got tachycardic, have a troponin leak. And so that MI post-op is a demand ischemia, and it is not because of coronary disease. The biggest mistake we see with coding sometimes is history of MI, CAD. No, you can have CAD without having an MI at all. So if you have a massive PE, you have a troponin leak, that's not because of coronary disease. So of the 3 pathways that lead to death and MI, which we try to avoid, the one that we think we can do something about is if you have a 99% lesion, we fix that, everything's going to be peachy for our surgery. Is that a true assumption? Okay, we spend a lot of time. Predicting rain doesn't count, building arc does, right? We spend a lot of time talking about should we or shouldn't we do this and order this test. The patient doesn't care. They just want to know, can you please take good care of me so I can go home to my family? Yeah? Okay, you'll love this. This is a very famous study called the CARP trial. Yeah, any study that starts with a fish is always good, right? Okay, now this is 18 VAs, 6,000 patients, mostly men, having vascular surgery. In order for you to be in the CARP trial, you have to have an abnormal angiogram. So you have a cardiac cath. This is very invasive. So known high-risk patient by having known anatomy, and you have to undergo a major AAA or major infraimmunovascular surgery. So this is a very high-risk vascular surgery. This is not having a carotid endarterectomy here. So high-risk patient by known anatomy from an angiogram and high-risk procedure. They excluded the following: people with left main disease, with systolic failure. So if you have a really weak pump, you shouldn't be in this study, and you have aortic stenosis on top of the coronary disease. These people need a CABG. They cannot be in the study. So they go from 6,000 patients down to 500. That seems like a small number, but you can imagine how invasive it is. I come to you for AAA and you make me have a CABG first. Yeah. So out of 500 patients going through this, and this is a Kaplan-Meier curve, which is called the survival curve. There was no difference between the two groups at 1 month and at 3 years. What does that mean? Well, I had an angiogram done, I get a CABG done, or PCI, stent, I have AAA repair, and it made no difference compared to people undergoing medical therapy. So we've gone through all of these. We order all these tests so we can put stents, CABG, we do all these things to treat us. We're not treating the patient. I certainly make our plaintiff attorneys, the defendant attorney feel good, right? But we're not really changing the course. Same with stent. We like stent because it makes us feel good, but there's several studies that show that the stent that are just placed are at higher risk for clotting off. Most of the stent clot off in the first year, and certainly in the first 3 months. And so surgery and stents do not mix, because surgery elicits this cascade of fibrinolytic, thromboembolic issues. So stent and surgery are not good friends. So this is an event registry. Registry is not an intervention. You have a drug-eluting stent at time 0, and they keep your name on the book for the next year, and then about 5% of them ending up with some kind of surgery. And you may say, yeah, but they're higher risk because they have surgery. People fall off ATV in Hawaii, get kidney stones, and, skateboarding for the first time, break an arm. So there are lots of reasons people have surgery, and not because they're high risk. So out of the 5% of those 5,000 patients who had stent having surgery, and what they found, there was a 27-fold increase in cardiac complication around the time of the surgery if you would have stent in the last year. So the point is, you should have cardiac testing because you have symptoms, cardiac symptoms, whether you have surgery or not. And you should have stent because you have symptoms related to severe angina, but you shouldn't have that in preparation for a surgery. So there's just a lot of information. I'm just going to go to the next slide. Beta blocker, right? So we've gone over revascularization. That's the ultimate intervention, right? If you have blockage, we fix you, and it did make a difference. So if you go to vascular clinic, when I was an intern in 1987, if you're going to have a femoral popliteal bypass graft, you can be certain that you're going to have a coronary angiogram. And then later on, people get Pasandin thallium and Dobutamine stratification. Now, Dr. Pevick and Dr. Dawson, they don't order any of that unless you have cardiac symptoms. Yeah. So the next one is beta blocker. This is the first study. It's a really weird study. VA San Francisco, 200 men undergoing elective noncardiac surgery, and they get a squirt of atenolol in the pre-op holding area, and they switch to PO for up to 1 week. They follow them for the next 2 years. There was no difference at the time of discharge, but starting 6 months to 2 years, there was a huge difference in death and MI. The question, I don't know what that means, and I don't. But that was kind of a weird result. So that leads to several other studies, and this is one of the more famous ones called the Dutch trial, Decrease 2 by Pullman. And this is actually mirror the CARP trial. In order for you to be in this trial, you have to have a positive Dobutamine stratification, so known abnormal functional study. And you have to undergo major AAA repair. And then the intervention is bisoprolol, which is a PO beta blocker, a selective beta 2 selective beta blocker. If you're going to get it, you're going to get it over a month before the surgery. and they follow you for 1 month. So it's an endpoint is a short endpoint. At 1 month, there was a significant difference in death and MI. The chance of this study to be pure luck is 1 in 1,000. So it's like, whoa. So what's the conclusion? If you're going to have a positive Riemann stress echo, you undergo major AAA repair, and if you have bisoprolol a month before surgery, it is cardioprotective at 1 month. That is the conclusion. Questions? Is it a drug effect or a class effect? Can I substitute bisoprolol to atenolol, metoprolol? Yes, I don't know. What happened if you didn't have a stress test? What happened if I have a hysteroscopy instead of a AAA repair? The answer is, I don't know. And yet, those 312 patients, 200 from Mangano and 112 here, were the basis for some of the recommendations for beta blocker in the United States for several years. And we were like, seriously? You know, what if I have an 82-year-old lady who come in for a postmenopause vaginal bleeding? Should they be on beta blocker? The answer is, I don't know. So Huong talks a lot for the last half hour and still doesn't know anything. Yeah, so you look at this data. Yeah, and so so everybody was unhappy with the recommendation. Oh, the other thing is that this study is so beautifully designed, but 15 years later, Polenberg was fired from Erasmus University for data fabrication. The question is, did he fabricate this data? Is it too good to be true? The answer is, I don't know. Yeah, so, you know, I'm sure when you call me and, you know, Huong would almost always talk for 10 minutes, say, I don't know. Yeah. Anyway, so let's go over the Lindenauer. This is a chart review of 800,000 cases. You know, that's a lot of boring work for a graduate student here. And they just dig through the chart and they score them. You get a point if you have heart disease, you have stroke, you have kidney disease, you have diabetes, you have high-risk surgery. And then what they found is that if you have 4 or more risks, the number needed to treat with beta blocker is 33. So that's a done deal. You treat 33 to save a life. That's very worthwhile goal. But if I'm a hypertensive, smoking, menopausal woman, I get 0 points. The number needed to treat is 2,300, and the number needed to harm is 200. The point is, benefit, risk, go for it. Benefit, risk, don't even think of it. Yeah. So it all boils down to what are the patient-related risks. So don't give beta blocker because the patient having surgery. Give beta blocker because there's some indication for that. They have heart disease, they have diabetes, they was post-infarct, and they gotten around to getting health insurance, now they see you. So those are the ones that should get beta blocker. And if you're going to give them, this is a POISE trial. Oh, you'll love this too. This is a Canadian study, 8,000 patients, 23 countries, and one of the common thread that you see with this pre-op study is that they are so, you know, they're so focused on cardiac patient and cardiac surgery. It's like, I'm sorry, you know, you go to Kaiser and maybe 1% of your case is going to be vascular surgery, right? And yet almost all the data is vascular cases. So here, nearly half the patients have coronary disease or strokes or something like that. That's not in the real world, right? And look at that, 42% vascular surgery. And so the intervention is metoprolol CR, so a long-acting metoprolol, and it's a really weird dosing. Does not titrate, which means if your systolic pressure at the time of your visit is over 100, you get full dose. If it's 99, you don't get treatment. And it's 100 milligrams before, 100 after, 200 every day for a month. And now, do you know what happened if you have a 90-pounder, a 90-pound, 80-year-old lady coming in with 200 milligrams of metoprolol? What would happen? So no big surprise. For 1,000 patients of similar risk, metoprolol prevents 15 non-fatal MI in exchange for 8 excess deaths, most of them from strokes. Well, duh, yeah? And now the question is, why was the dose like that? You know, the person who designed the dose was the original scientist in the YECI trial, the Italian study. So it's just very odd. So that's what you're stuck with. You have all of these data and you don't know what to do with them. Now, in terms of the stroke and the stroke death, they put all of these vascular studies together and they run them again, and they see that if you were to give any beta blocker, you titrate them, meaning you slowly increase the dose over a period of a week and a half, the incidence of stroke actually is very low. So it is not a good idea to give 200 milligrams of beta blocker around the time of surgery. Yeah. So the points are, 1, why you have the surgery. 2, what are your medical problems? Among the medical problems, what are the modifiable risks? All modifiable risks need to be tuned up, optimized before surgery. What is the function? Do you understand your choice? Yeah. In terms of when would you study for testing? Well, the function is everything. If you cannot do function, if there's some cardiac risk, then you can do this testing, but you just need to recognize that this testing has limitation. I mean, we would never use a pager that doesn't go off, right? Or maybe we want to. Or a pair of glasses that are fuzzy. So we do stress tests all the time, but the stress test itself has limit. It is very good if it's negative, but if it's abnormal, you don't know what to do with them. Likewise with beta blocker. You should get beta blocker because you have a specific reason for beta blocker and not simply in preparation for a surgery. Okay, now we all... So I hope you get a copy of this slide because, you know, it go over what are the recommendations and, you know, I'm just going to spend about 10 minutes on diabetes. Okay, remember like Mary Poppins, a teaspoon of sugar? A teaspoon of sugar is 5 grams, okay? Now, the pre-diabetic fasting guideline is, if your finger stick, 100 to 125 milligrams per deciliter. Since we have 5 liters of blood in our body, 100 milligrams per deciliter means we have 1 teaspoon of sugar in our bloodstream is a definition for prediabetes. And we're not talking about extracellular fluid or others. But, you know, I just want to prove a point here. Now, you go to Starbucks because we're late for breakfast, late for work, yeah? So a 16-ounce cafe mocha is 36 grams. That's 7 teaspoons of sugar in a 16-ounce drink. And there's a, I don't know, caramel cocoa cluster. I don't know what that is. 76 grams. I mean, having insulin shock just looking at the amount of sugar in there. So if we were to have a cafe mocha, and that's not even counting, you know, the muffin and the scone and everything else we eat, right? Does our sugar go up, our fasting finger stick go up to 700 milligrams per day? I mean, not fasting, but our postprandial finger stick go up to 700 milligrams? Of course not, yeah? The question is, where did it go? Right? It go in our mouth, we know that, right? But the question, where does it go? Okay, a lot of it goes into our liver. So the liver on your left, on your right is the fatty liver, and you see those little white bubbles in there? A lot of it gets stored. And so sucrose, the table sugar, is a disaccharide. It has 2 components. Glucose, which your body can use for fuel, and fructose is a storing fuel. And so it increases your insulin level, but it goes into your liver. So when you see a child, my own children included, you know, okay, here, catch a Gatorade, Powerade will help you play soccer better, yeah? No, that all of that fructose go into that child's liver. It cannot be used for fuel. So that we flunked Chemistry 101 just based on that alone. So, you know, this is a really weird disease, is that, you know, we will never tell our parents or our, you know, cousins with lactose intolerance, oh, eat more lactose, I'll give you pills and shots. Or with celiac disease, eat more gluten and we'll take pills and shots. But in diabetes, we do. We ask somebody to take something that they cannot use very efficiently. The question is, why is that? You see, in medicine, we're taught to be obedient. We just kind of follow all this guideline and we just carry out because there's so much to know, and we rely on somebody else to tell us, you know, what the most recent data and informations are. But the problem is that we even though we know that's an insulin resistance and carbohydrate, you know, intolerance condition, we eat them, yeah, because we make the assumption that our brain needs glucose for fuel. Is that a true assumption? The answer is heck no. You know, when you were born, a newborn child is in a ketotic state, so glucose is not an obligate fuel for the brain. And so it's a little of a cognitive dissonance to tell somebody who cannot process glucose to eat more sugar. And so the treatment we have are fourfold. The first treatment we have diabetes are a sensitizer, which makes sense, right? You take something that help your end organ use insulin and glucose more efficiently, right? So that's like a biwanite, like metformin. Yeah, that makes sense. Now, because it's a sensitizer, it does not change your body insulin. So if it doesn't change your body insulin, then hypoglycemia is not going to be an issue. And weight gain is not going to be an issue because insulin is a storage hormone, right? You eat insulin, your weight's going to go up. Everybody knows that. And so that makes sense. So sensitizer makes sense. The second group of medication, there's several of them and 7 classes, called a secretagogue. Secretagogue means you take something that whip your pancreas into cranking out more insulin. So you increase endogenous insulin, meaning insulin inside our body. So if you see somebody take glipizide, you know they have a functional pancreas and they cannot be a type 1. Right? Now, over time, we're probably going to change the term type 1 and type 2 because that's, early 20th century, mid-20th century name. Now, I think the insulin resistant and insulin deficiency will probably be a better explanation of what the underlying physiology is. So, if you take a sulfonylurea like glipizide and glyburide, it make your body make more endogenous insulin. If your insulin goes up, hypoglycemia is going to be a problem, so that's a side effect, and then weight gain is going to be a problem. Yeah, and then there's several others like the meglitidine, like pranglin and Starlink, the DPP, the PPAR inhibitor, and the GLP-1. So that's a glucagon inhibitor, glucagon-like peptide. Those are other form that you can use is a secretagogue. Remember, you take a secretagogue. So whenever you have a new, you're watching your favorite TV show, and ask your doctor about Farxiga. No, you just have to ask, what does it do to insulin? That's all you have to ask. If it increases insulin, you actually make the condition worse, right? You treat the blood sugar, but you increase the endogenous insulin, which is the thing that you don't want in someone who has metabolic syndrome, right? So 2 is a secretagogue, 3 is an absorption. So absorption is a form of purging, right? So we eat the glucose we can't tolerate, and then we take a pill to get rid of that. And you only get rid of it to 2 ways, to your gut and to your kidney. So alpha-glucosidase inhibitor like Precoz or Carbose it tells your intestinal villi don't absorb that, just let that carbohydrate go through. So it's a pass-through. So it's a form of purging. We eat a food that we cannot tolerate, and then we take something else to purge that through our gut. So if you talk to anybody who uses that, oh, this is worse than bean. I never take them when I go to a wedding because I'll be passing gas left and right. And so that's 1. And 2 is the new one. This is a sexy one here. This is a sodium glucose 2 transport inhibitor. So this is the gliflozin, the Farxiga, the Invokana. You watch it on TV all the time. And so you take a substance that you cannot tolerate. You take a pill that tells your kidney to pee it out. So you induce a glycosauric state. And so it just doesn't make sense. Right now it's a darling of a drug because it actually associates with weight loss. Everybody loves this. But carbohydrate is a very inflammatory product, right? So besides UTIs and vaginitis, which are treatable, I don't know what happened. If you have a family history of kidney disease, kidney cancer, what would happen to you 10, 15 years from now? The answer is, I don't know. This drug is only 6 years old. So there's going to be some unintended consequence that we don't know. But you look and say, why are we asking somebody who cannot tolerate carbohydrate taking more? So that we can give them medication that actually make the condition worse, right? So it's just very odd. And then obviously you can give exogenous insulin. So you give, insulin. And you can tell, you and I make about 15, 20 units a day. Somebody take 200 units of insulin, that's going to be a very insulin-resistant person. And we know we make that condition worse with hyperinsulinemic state like that. So what do we do when we do pre-op? Well, there are lots of studies, and the big one came out, the Duberg study with intubated trauma patients, right? Tight control, meaning your finger stick 80 to 120. Was what was used. So remember there was a time in the SICU, everybody's on insulin drip, yeah? And then same with cabbage patients, that it helped with wound dehiscence and things like that. But when they put all the studies together and they found that there's actually, and the other thing is that my patient's just going to have a hysteroscopy. What should I do? Yeah? And the mortality, the deaths in 3 months and 6 months, so short-term and long-term mortality is not different, yeah? But there's a huge difference in hypoglycemia. And in the middle of surgery, having hypoglycemia is not a good thing to have, yeah? And so, what do? The answer is, I don't know. So, first we have to do is, are you a type 1 insulin deficient or type 2 insulin resistant? If you're type 1, you have more, obviously, if without insulin, it can be fatal. You can have diabetic ketoacidosis. So if you're type 1, you should have surgery early in the morning to prevent fasting. You should get some insulin on board, and so because you cannot withhold insulin from a type 1, it's a life-saving treatment. So how brittle is your diabetes? If the one patient say, oh, my sugar go from 40 to 400, okay, first case of the day, right? Yeah. Now, ask them, do you check your sugar before you eat or after you eat? If you're going to do it after you eat, how many hours after you eat do you check your blood sugar? What's your batting average? So in the last 2 weeks, what's your usual numbers? 180. Or my range is from 120 to 190. So, okay, that's, pretty stable for that person. What's your usual sugar? How low does your sugar drop before you get the shakes and sweaty? Hypoglycemic awareness. That matters, because if someone says, oh, if it goes below 60, I can feel it. That some person has an intact alarm clock. But if they say that, oh, I can go down to 20, I wouldn't know. That's a big deal. You never want anybody to be hypoglycemic, because hypoglycemia can cause irreversible brain damage. It's very, very serious. And so right off the bat, we want to avoid hypoglycemia. Yeah. We want to prevent severe hypoglycemia. Okay, Hong, define hypoglycemia. I don't know. We kind of pick a number like 180 to 200. Pick whatever number you want. Yeah. And then, so do you have any other complication? The big one with surgery is, do you have gastroparesis? Do you vomit a lot after you eat? Because some diabetic patient has an autonomic dysfunction and they vomit a lot. And if they increase the risk of vomiting, we need to, anesthesia would want to know this for the risk of aspiration. And then, obviously, the type of surgery. Sometimes you see someone who's on like a 2-day bowel prep. We need to adjust the insulin the minute they change the food intake and not just the day of surgery. So we want to kind of go through that process. So the rule of thumb is, this is just very anti-intellectual, and we just make it so that we have something in writing. If we're not going to eat, no food, no oral hypoglycemic, and no non-insulin injectable. And that would be, some of the injection we talked about earlier, or short-acting insulin. So no Lispro, no Humalog. And we just use this, because we need something. If your usual morning fasting sugar is less than 150, we should decrease your night dose of the long-acting insulin the night before down to like 50% or 80% only. Yeah, pick a number. Right now we've been using 50 because it's easier to divide 12 into half than 12 into 80%. Yeah. So the point is, if the morning sugar is low, then you want to cut the lentils the night before down proportionally so that they don't bottom out in the next morning, the day of surgery, when they're fasting. If they're on the pump, then we just say, well, cut it down to 80% of whatever your basal rate is. And so it's the goal is avoid hypoglycemia, avoid hyperglycemia. Define hypoglycemia, I don't know. We usually use 200s, but again, we're not sure. There's no study on this. Okay, I'll set up now. I'll answer questions. Do you have any questions? Thank you.